Hello, everyone. Welcome. Thanks, everyone, for coming in person. Thanks, everyone, for joining us online. I'm Natasha Christie Holmes. I'm the Director of Strategy and Partnerships for EPIC, and I'm really excited on behalf of EPIC, the Institute for Pandemics, and the Temerty Center for AI in Research and Education in Medicine to be introducing our first session of a speaker series that'll run this fall. We have one session today, a session in October, and a session in November on AI and infectious disease. Before we get started, I'd just like to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. We also wish to acknowledge the devastating impacts that infectious disease have had on Indigenous peoples in the past, and the disproportionate harm they continue to inflict on Indigenous and other equity-deserving communities today. As a community of researchers and clinicians, it's incumbent on us to ensure that our work does not perpetuate these harms and actively seeks to address health inequities in Canada and around the world. So we're really excited to kick off our series today with a talk and a discussion about strengthening readiness and resilience in an era of global epidemics. And we're extremely excited across all three of our sessions to welcome a wonderful moderator, Ivan Semeniuk from the Globe and Mail. Ivan has been covering science for the Globe and Mail for the last 11 plus years. And covering science is a massive beat, obviously, that ranges from astrophysics and space exploration down to tiny microbes and their effect on human health. He's been covering the most pressing issues and discoveries related to all of those things. He holds an undergraduate degree in astronomy and physics from the University of Toronto and a master's degree in science journalism from Boston University. He has been an instructor and researcher at the Ontario Science Centre. He's taught courses in science, environment, and health reporting at Carleton, and has developed a popular introductory class on science media here at the University of Toronto. His work in various media has garnered several awards and nominations, including being named the 2015 laureate of the Sanofi Pasteur Medal of Excellence in Health Research Journalism. And in 2016, he was named a recipient of the Royal Canadian Institute's Stanford Fleming Medal for his contributions to the public understanding of science. With that, I'll hand it over to Ivan to kick off our session. Thanks.
Thank you very much, Natasha, for that introduction, and thanks to all of you for coming today. I think we're going to have a very interesting panel and also kick off a series for the fall. I like to stay out of the way of panelists as much as possible in my role as moderator, but I am going to elaborate. I'm going to take this rare occasion to elaborate on one line of the bio you just heard, which also included time at Nature and New Scientist and Discovery Channel. But before the 25 years of science media experience I had that brought me to be here on this panel today was that time at the Ontario Science Centre, where I had the opportunity to learn and develop my skills, the process of communicating science to the public in the public's interest. And I just want to mention this because for the first time in 55 years, that opportunity, both for young students and for professionals learning to communicate science, is not available to us here in Ontario anymore. And I think we need to reflect on what is needed to create a smart society, which is, of course, why we're all here. Anyway, I'll stop preaching now, but I just wanted to make sure we reflect on that. So we have a panel here to talk about AI, and today, AI in the context of strengthening readiness and resilience in an era of global epidemics, which, of course, if there was any doubt, we now know that we are in such an era. We will start off with our keynote speaker, and then later we'll invite our panelists up for an engaging discussion. And as I often say to students when I'm teaching, especially when I'm teaching science media or journalism, you always have a question ready. So I'm going to warn you now, have that question ready. Be prepared to have more questions in your back pocket as well, because we'll certainly be turning to you. This is our chance to really have an engaging conversation. But first, it's my pleasure to introduce our keynote speaker, and then we'll come back and introduce the remaining panelists. Our keynote speaker today is Dr. Kamran Khan. He is a practicing infectious disease physician as well as a professor of medicine and public health here at the University of Toronto, where he holds a Temerity Health Nexus Chair in Innovation and Technology. Motivated by his experiences as a frontline healthcare worker during the 2003 Toronto SARS outbreak, landmark turning point here in Toronto, Dr. Khan has been studying outbreaks of emerging and re-emerging pathogens for nearly 2 decades to lay the scientific foundation for a global early warning system for infectious diseases. His research has been published in leading journals from the New England Journal of Medicine, the Lancet Science, Nature, and Cell, among others. Dr. Kamran's work during global health emergencies such as the 2014 Ebola epidemic in West Africa or the 2016 Zika epidemic in Latin America has led him into numerous advisory roles from the World Health Organization to the White House. And of course, I'll just mention that he is also known here, of course, as a translator of science into the marketplace and to disseminate scientific knowledge into timely action, which led him to spin off the company BlueDot in 2013. This is a biothreat intelligence company that combines human and artificial intelligence to help governments protect their citizens and businesses protect their operations, employees and customers from disruptive infectious disease threats. It's been featured in numerous media reports and of course was well known at the outset of the COVID-19 pandemic for having a hint of what was coming in the very early days of the pandemic. So without further ado, please join me in welcoming Dr. Kamran Khan.
Okay, thank you for that kind introduction, and good morning, everyone. Let me just kick things off in the interest of time here. So just in terms of a disclosure, as Ivan had mentioned, I'm the founder and CEO of BlueDot, which is an infectious disease intelligence company. I'm just going to mention a little bit about the learning objectives. I'm going to talk a bit about language models and how they can enhance global epidemic surveillance. I'm going to talk about the complementary roles of machine intelligence and human intelligence. And finally, I'm just going to describe some real-world examples of how surveillance can be transformed into actionable health intelligence across a variety of different sectors, public, private sector organizations. Okay, just to kick things off with a little bit of context. Ivan mentioned I've been kind of in this area since 2003. It actually goes back to 1999 when I was doing my fellowship in New York and this new virus, West Nile, showed up in Queens. So in the last 25 years, we can see there have been a growing number of outbreaks. And in fact, since 2009, so what is that, 15 years, there have been 8 public health emergencies of international concern declared, the latest one just very recently with Mpox. So if you do the math, that's basically one infectious disease emergency of international or global concern about every 2 years. So clearly this is a problem that is not going away. In fact, 2 of these are pandemics, by the way, 10 years apart from one another. So this is a problem that is going to be here with us for the foreseeable future. So let me just get that bad news out of the way, and we'll get on to the reasons for optimism. So in light of the fact that this is an ongoing challenge, if we are going to get ahead of these threats, we're basically going to have to move faster and smarter and be better coordinated than we've ever been before. Now, we're going to need to, in order to do this, we're going to need to be able to identify threats anywhere in the world, and we're going to have to do that quickly. We're going to need to anticipate which of these threats actually demand our attention, because maybe they're likely to spread or amplify or move to one place to the next. What populations are going to be at risk or most vulnerable. And then ultimately, we have to turn those insights into action. And we're going to have to do this quickly. We got to get from identifying the threat to making a decision and acting quickly. Again, if we want to be ahead of these threats, which we know can spread incredibly fast. So let me just first of all talk about identifying threats and sort of public health surveillance. And, we have a bunch of different means to gather information about what's happening around the world. We have indicator-based surveillance, reporting of notifiable diseases. So if I see a case of measles, I've got to report it to the public health entity. It's on the list of notifiable diseases. But we also know that that information isn't always timely, and maybe in some instances, it may not be actively disclosed. So event-based surveillance reflects ways that we can actually gather information through vast medium like the internet. And all of this is unstructured text data, but we may get early clues that something is happening ahead of it being officially reported through the indicator-based surveillance system. We have syndromic surveillance. There's surveillance of infectious diseases in animals that may spill over to humans. We have wastewater surveillance and environmental surveillance. There's a whole bunch of these different domains. I think a really important thing to recognize, however, is that alongside this, there's a lot of intelligence that exists within the healthcare system. And it's not as easily accessible because there's personal health information, privacy concerns. Our information systems are not operating in real time and all structured for real time data and analytics. I know that is evolving and there's some really great work that's happening on that front. But things like, billing visits, who's coming in to see their clinician to their primary care provider for what reason, healthcare provider notes, unstructured text can provide some insights, prescription drug use, for instance. So these are some really important ways that we can gain insights into what is happening in terms of surveillance of infectious diseases. And this is a broad ecosystem that ultimately, if we want to be able to identify threats early, we're going to need to be looking in multiple domains that you see up here. Now, I've only got 15 minutes to speak. I'm just going to talk about one of these, and this is event-based surveillance, because this is an area that BlueDot does quite a bit of work in. And when we're talking about event-based surveillance, as I mentioned earlier, we can't always rely on public health agencies somewhere in the world to notify us that maybe something is happening within their borders. Either they might not be aware, or there may be, fear of economic or political or other consequences. They may be withholding that information, so we lose time. Of course, the internet is this vast medium in the world's many languages. How do you go find the needles in the haystack? And so here is where we have been using natural language processing and language models. And we've been doing this long before OpenAI's, ChatGPT, to train a system to go through the world's many different languages, about 130 different languages, every 15 minutes, 24 hours a day, look for early clues of outbreaks of known pathogens or syndromes. And then ultimately, as we gather all that information, we compare it to historical data to get a sense of, is this consistent with what we've seen in the past? For instance, is this a pathogen that we haven't seen in this geography before? It's not been in that location. Or if it has a seasonal pattern, is it occurring at an unusual time of year? Or maybe the number of cases we're seeing are in excess of what we would normally expect for that location and time. Or maybe even the clinical manifestations are not consistent with what we've seen in the past. So this is where, we kind of call this anomaly detection. And the question is that event that we've identified, is it unusual? And if it's unusual, it warrants more of our attention. We've also been using natural language generation then to take a lot of this text and create a synopsis or summary of it. As you can imagine, it's a lot of information, and generative AI now can help us create summaries of this. But then we also have human oversight. I think what we've seen certainly is that machines, have certain capabilities. We want machines to play to their strengths, but humans have reasoning capabilities. And so we can look at things and go, that seems a little unusual. Maybe we should work on verifying if this is real, corroborate the information. And our team includes infectious disease physicians, veterinarians, other public health experts. And so we're often doing a bit of, we sometimes call it investigative journalism, going out there and gathering pieces of information, connecting the dots, trying to create a narrative. And so it's this pipeline that you see here that we're doing every single day, continuously around the clock, of ingesting information. This is just one domain. As I mentioned, there are all those other domains of surveillance that I was talking about earlier. But this is how AI can help us. And here's one example. I realize we're going back almost 5 years now. Hard to believe it's that long. But in late December 2019, this surveillance engine picking up that there's kind of rumors of an unusual respiratory illness circulating in Hubei province. And then we send this out the following morning to all of our clients and all of the partner organizations that we work with. But that's one example. This is happening continuously around the clock. And so here's just a visual representation over the span of a year of all the kinds of information that's gathered across the globe, sifted through, organized, structured, and so forth. Now, when you look at this here, every single data point, and there are hundreds of thousands of data points, actually probably millions of data points here, they're relevant to someone. But the entirety of this information, I've learned, is relevant to no one. There's no single person who wants to consume all of this. And this is a really, I think, important challenge, is that that's a lot of information to consume. And so ultimately, if we think about how do we make this actionable, we've got to direct the information to the audience that needs it exactly when they need it. And that's not an easy task. I'm going to talk a little bit about how we can do that in ways that makes this relevant to the audience. You can imagine if I just dumped a lot of information at you, you would quickly start to tune out because it'd be too much information that's not relevant to you. I love this Professor Shirky's quote here. It's like, this isn't an information overload problem. This is a filter failure problem. So here's one way that we think about relevancy. And when I think about, filter failure and I think about relevancy, where you are in the world is one really important factor. So for example, if you've got, we're talking about this clade 1 Mpox outbreak in Central Africa. If you're in San Francisco, or if you're in Sao Paulo, or you're in Stockholm, the world looks very different to you. Those risks it's not a level playing field. But ultimately, what we have to think about is how the world is connected. And this image here is a reflection of data that we use at BlueDot. It's on billions of ticket sales on commercial flights. So this is an actual representation of what the whole world's interconnectedness looks like. And so we can use this to gain some insights about what's relevant to you wherever you happen to be located. Now, I was just at a pandemic summit in Brazil and that CEPI had hosted, and it was really interesting. In the Q&A session, someone put up their hand, and I thought it was maybe one of the most profound questions, which was like, okay, you've got more and more data. What does this mean for me? Like, what do I do with this? And I think this is a really key question that we need to be considering if we're going to make this surveillance data and intelligence actionable and meaningful. So this is just a visualization of how during the early days of COVID, this was back on December 31st, 2019, we had looked at how populations were moving based on ground travel around Wuhan to neighboring airports, and then how those airports were connected through not only actual flights you see in yellow, but the final destinations of travelers and where they were going. So this is kind of helping to anticipate, where do we think this outbreak might go to next? And so because, our team was quite concerned about what we were seeing back in late December 2019, we decided this could be the real deal. This could be quite significant. And so we actually published this manuscript. This is actually, it turns out, this is the world's first peer-reviewed study on COVID-19. You can see the title, it's so early. It's called Pneumonia of Unknown Etiology. It hasn't been confirmed to be from a coronavirus at this point. So we're using this approach to sort of, we kind of describe it anticipatory surveillance. Where should we be heightening our surveillance, kind of looking downstream? And I just wanted to point out two cities at the top of this list, Bangkok and Tokyo. This was the first time in my academic career of 20 plus years that we'd actually publish something in advance before it happened. I mean, almost every other publication I've done, by the time it's gone through peer review and so forth, it's always been looking in the rearview mirror and being like, oh, that's interesting that things played out in this way. But Bangkok and Tokyo, and then I point this out because 5 days later, the first case of COVID-19 outside of mainland China was confirmed in Bangkok. And then 3 days later, the second in Tokyo. And it turns out that list, actually, most of those cities were the first cities that were impacted by COVID-19. But I'm saying this not just because, this is like, okay, where do we think things are going next? This also provides some really valuable insights because we know surveillance is not perfect. And in fact, when you're dealing with an emerging disease, you're seeing often the tip of the iceberg. You're just seeing those severe cases. So you don't really fully understand the spectrum of disease. But we know, and we can actually, take the observations of cases in another country, knowing the structure and capacity of the global airline transportation network and how it is organized, we can then start to infer that statistically, it's not plausible for there to be a few dozen cases in Wuhan. There has to be at least 2 orders of magnitude greater number. There are thousands, possibly tens of thousands of cases there through these observations. So I think it's also important that there's interesting ways that we can think about looking through some of these surveillance gaps. I'm going to wrap up with a discussion about getting from insight to action. My experience during COVID was this is actually the hardest thing because it involves humans, and humans are kind of challenging creatures and so forth. But again, all of the speed that we generate with AI and all of these advanced analytics, if we lose time on the back end, we just wasted all of that effort. So we've got to figure out, how do we communicate this? How is it consumable? How do we get it into workflows? And one of the things we learned was bring the intelligence into the workflow of your users. We used to have software that we would say, come into our workflow, take what you need and take it back to your workflow. And we quickly realized that is slow and inefficient and you lose time. So not to get too technical, we started focusing on APIs and data services and bringing our intelligence into the business intelligence solutions that our customers were using. So I'm going to maybe shift a little bit. As Ivan mentioned, I have a Temerty Chair in Health Innovation and Technology. And part of the reason that I founded a company was because we needed to be fast. And my experience was the academic sector had certain strengths. So speed wasn't necessarily one of them. And I'd seen enough panic neglect cycles with outbreaks of like massive amounts of funding to respond and then evaporation of funding and so forth. So the question was, how do we actually do this in a way that is fast, where we can create things, break them, recreate them? But we're going to need a different business model. And so this is, for me, I will say, a leap of faith. It kind of felt a bit like that guy jumping off that cliff. Because I was like, I do not know anything about running a company. I'm an academic. I'm a clinician. But ultimately, this was the path that we took. This is almost 11 years ago now, of really driving innovation. And I'm just going to share a few examples with you. Using the same data, again, this is a whole of society problem that we're talking about with epidemics and pandemics, is we support governments around the world in about 24 countries to protect their populations. But it's not just public health. National defense organizations like NATO uses our technology and our intelligence to protect the armed forces wherever they're deployed in the world. Through our partnership with Global Affairs Canada, Interpol is using our technology to look for outbreaks that have unusual features that might signal a deliberate act. We work with pharmaceutical and life sciences companies that want to understand, where are those vaccines and therapeutics and diagnostics, et cetera, where are they going to be in demand, so they can try and make sure that they are being deployed into those particular locations. But many of them are also looking to educate frontline healthcare providers. Like, I'm an infectious disease physician, this is all I think about, but I would say there are lots of clinicians out there, probably 95+%, who aren't thinking about infectious diseases, aren't trained in these diseases, but their life depends upon it, their patients' lives. There could be an outbreak within their institution or in their community. So we need more astute clinicians. We got to bring this intelligence to them. And then finally, healthcare consumers, or the public. I'm just going to mention one example. Amazon is actually one of our clients, and we work with them. They have like 1.7 million employees around the world. And our intelligence kind of helps them from an employee health and safety perspective. So they know what's happening outside those distribution centers. Is it a case of measles? Is it something else that could impact the health of their employees, increase absenteeism, disrupt you may not get your delivery on time. So these are just a few examples of how we can use the same surveillance and intelligence to work across sectors to really have an impact on strengthening readiness and resilience to the threats we know that we're inevitably going to face. So I'm just going to wrap up here. Hopefully this was some food for thought that kind of kicks off our discussion. But I just want to thank you again for having me here today. And I think, Natasha, I believe I'm supposed to move to this slide, or do you want me to end here? Okay. Okay, thank you so much. Yeah.
We have our panelists now, and I would like to introduce the rest of the panel for you. and then we'll go on to the discussion part of the event. And again, I encourage you to have your questions ready. So first, I'd like to welcome Michelle Murti. Why don't we bring Michelle Murti and Fahad Razak both to the stage? Please have a seat. Thank you very much. And I will just quickly introduce them now, and then I'll ask you to join me in welcoming them. Professor Murti is a public health and preventative medicine physician and an associate chief medical officer of health with the Office of the Chief Medical Officer of Health, Ministry of Health for Ontario. Her expertise is in communicable disease control, surveillance, and emergency preparedness and response. And she's provided extensive scientific and technical advice on public health case, contact, and outbreak management guidance for the Ontario COVID response, as well as policy advice on public health measures. She's a member of the Canadian Pandemic Influenza Preparedness Task Group and the High Consequence Infectious Disease Working Group of the National Advisory Committee on Immunization. Professor Murti is an instructor in emergency preparedness for the Master of Public Health program here at the Dalai Lama School of Public Health. Her research interests include influenza and emerging respiratory viruses and syndemics-based approaches to communicable disease surveillance. She has also completed fellowships as an epidemic intelligence service officer at the Center for Disease Control and Prevention and as an emerging leader in biosecurity at Johns Hopkins University Center for Health Security. And she's worked in public health and Public Health Ontario, Fraser Health Authority in British Columbia, and practiced clinically in Ontario and New Zealand. Dr. Fahad Razak is an internist and epidemiologist, and his research focuses on improving the care of hospitalized patients through application methods to hospital big data. He co-founded Gemini, which is the largest hospital research network in Canada and one of few such examples globally. Gemini covers 60% of Ontario's medical hospital beds, making it a living laboratory to study hospital care. Dr. Razak completed an engineering science degree, medical doctorate, and residence at the University of Toronto. He was the first physician to be appointed the David Bell Fellow at Harvard University. Notable research recognitions include Canadian Society of Internal Medicine's New Investigator Award and the Graham Farquharson Knowledge Translation Fellowship from the PSI Foundation, and has been a recipient of funding grants from CIHR, NSERC, and Canadian Cancer Society. And also relevant to our conversation today, he was the scientific director of the Ontario COVID-19 Science Advisory Table, which of course played a crucial role in the public response here in Ontario. So please join me in welcoming our panelists, Dr. Michelle Murti, Dr. Fahad Razak. Okay. Everyone knows everyone, and we'd like to carry on this discussion from this keynote address. I'm going to put a couple of questions to our panelists. I'm going to make myself comfortable here, but again, I'm going to keep an eye on the time and on the audience as well, so we can get in a few questions from you as well. So, Dr. Khan, I'll start with you, but then I'd like to bring in the panel as much as possible. I'm going to start with a practical question, which I actually gave you some time to think about, because I think in the past few years, we have encountered AI and the potential of AI in virtually all aspects of our professional and in some cases our personal lives. And I think the public response to this has sort of been a very jiggly needle that goes back and forth between sort of excitement or even a bit of hype to skepticism about, how soon or how much of an impact can this have. And as we've learned about, how machine learning works, how large data sets power neural networks, and how large language models do their job, the importance of training data and sort of the integrity of that training data has, I think, become more of a matter of public understanding. So I want to put that to you, Dr. Khan, in the sense that, we know now that AI can write a thank you note or a term paper, unfortunately, but to do the kind of work that you're talking about, what is the training data and how, to what extent does it limit what we can do?
Thanks for that question. I think first of all, just to kind of recap that ultimately, when we're talking about machine learning, we're looking for patterns in data that we have that's historic data. So But I also want to highlight, as we're talking about emerging infectious diseases, there may be no historic data. So we may be dealing with some we've never encountered before. But the way that we've been doing this at BlueDot, and I'm going to just talk about event-based surveillance because we could probably spend hours going through many different areas. But ultimately, we're using open source data as our training data set. And so we're gathering information across the world's many different languages, and picking up some of the early information that maybe there's an outbreak occurring. We've done training. In an old interview, I used to use the example of are we talking about the rock band anthrax, or are we talking about an outbreak anthrax? So we use a lot of supervised ML to start classifying this information. And ultimately, as we do this over time, the system becomes smarter and smarter. Now, an important gap, though, however, is that when we're dealing with emerging diseases, they may be appearing in many low and limited resource countries where we actually don't necessarily have the same depth of information. And so that can be a bit of a challenge. So we've been working in, getting into new languages, but we're also using our clients and partners to tell us about other sources of information that may not be as readily apparent to us. It might be local forums, online blogs, et cetera, where we can start to actually gather additional information. But I think the point that you're making is the training data set is crucial in order to be able to essentially get the machine to kind of replicate how we would normally classify things. But this is an ongoing process. We're continuously reassessing and retraining the systems because we know that misinformation starts to leak in over, the landscape is changing. And so we have to constantly be on top of this.
Got it. And what I'm also hearing in that answer, and I think this applies to so many areas of pandemic preparedness, is the importance of international partnerships, because without it, you really can't get the car started without that.
It's a global problem, right? I mean, you've got to be looking at every corner of the planet. And so you can't do that alone.
Got it. So let's bring in Dr. Murti and also Dr. Razak. I'd like to speak to each of you in turn, sort of on the receiving end or on the client end, perhaps, of this type of capability from a public health perspective and also from a clinical surveillance perspective. So let's start with public health. Let's imagine that we have this capacity growing, becoming more powerful. In what way, Dr. Murti, could AI-informed surveillance then translate into public policy? How does it become relevant from a public health response?
Yeah, I think it's a really great question. And I think Dr. Khan alluded to it. The slowest part of the ship is that translation. And we know that that's true in terms of really being able to use that data. And then it's a translation of government. And we know governments can act quickly, but they can also act like the Titanic and be really hard ships to steer. And also changing the hearts and minds of people, because I don't think our COVID failures were around the scientific. I think we actually did extraordinarily well in terms of our scientific advances, in terms of our surveillance, in terms of understanding, what was the threats, how do we need to address it, record-breaking times for vaccine development. Some of our biggest challenges were reaching people, and that's what was going to make a difference in the pandemic, reaching people and reaching all people. And I think thinking about that equity lens to it, we can scrape the internet, but a lot of First Nation communities aren't communicating that way. And so how do we understand and bring into the voices of the surveillance that we need to have across the province, reaching all types of people, whether they're on the internet or not, and we can scrape their data, and think about also the ownership of that data too, to think, how are we understanding that data? Is it fair to scrape some of this data and put it into context and make sure that we're using it for that action for public health? I think if you think about, I'm co-chairing the redevelopment of the Canadian pandemic preparedness plan that, last was developed, after 2009 H1N1. And so if you could think about each chapter we're talking about, so obviously surveillance, there's huge AI implications that we're talking about. The drinking from the fireman's hose, in terms of being able to just think about the vast amounts of publications that came out through COVID. We definitely need AI to help us sort through that, because it was just too much information for anybody to try to digest. And if we don't have better tools to be able to synthesize and understand that, we need that. But some of the most critical parts of the pandemic plan is in that misinformation, building of trust, building of communities, like having that local trusted voice who people are going to listen to and not be in an echo chamber of AI generated, same thoughts, same disinformation. So I think we need to really think very critically about how we're going to apply it in a way that actually changes hearts and minds of people, because that's what actually makes a difference in a pandemic.
Okay, well, let me explore that a little bit further. To what extent is AI a helper or a hindrance in that, in the importance of dealing with misinformation?
I think there's huge opportunity. I mean, I think we've seen, there's no way that people can respond to the amount of information that's out there. So having, good information that's out there and having AI being able to respond to misinformation, to correct that, to provide the good information, huge opportunities that we have there. But we also know, I mean, if any of you are on Netflix or Spotify or any streaming app, would you like to listen to this? You might like to listen to this. Like, we know that there's already AI pervasive in our environment that is thinking about what we like and will only feed you more of what you like. So if there's someone out there who sees that disinformation, is interested in it, you will very quickly fall down a rabbit hole, and that is the only information that you'll ever be exposed to about it. And so you'll never even have that opportunity to have a different opinion or different voice of what other is good and credible information. And it can feel very credible. I mean, people got duped by an AI generated Joe Biden telling them don't go out to the election polls. If it's that good, we are in serious trouble if people want to use AI for bad in terms of being able to provide erroneous messages. And that's, if you fundamentally, we still need people to come out and get vaccinated, or, please stay home when we tell you to stay home. We need to have that credible message, and we need people to understand what is that credible message and be exposed to it. So I think we need to really think about what kinds of guardrails we're putting up into AI to say, no, we need more accountability from systems and from media to say, no, that is misinformation. That needs to come down. You cannot be perpetuating that. You need to be promoting the right information, because that is, how we're going to be able to reach people when we need to.
Okay, well, let's move the conversation now to another sphere, which is to bring in, get right to the front line. And Dr. Razak, I know you want to make the distinction between public health surveillance and clinical surveillance. I'd like to have you walk us through that, and specifically where you see AI as a relevant tool. What would make it a relevant tool?
Yeah, thanks, and pleasure to be here with Michelle and Cameron. So when we talk about clinical surveillance, I think you saw on Cameron's figure where traditional surveillance sits. It sits in things like testing centers. Over the pandemic, we saw innovations in areas like wastewater. There is a great untapped area of data which was not harnessed largely in this pandemic to inform either the science or real-time decision-making, which was all of the data that sits in clinical repositories. Why was it not used, and what could it be used for? So we're talking about things like the patients who show up in emergency rooms or in family medicine clinics, what kind of symptoms they have, especially when you're talking about an undifferentiated illness like it was early in the pandemic, what kind of therapies they receive, how they respond, what happens to them afterwards. All of that data, you can imagine, is incredibly important. And then connecting those patients to trials that are testing the latest therapeutic, ensuring that their vaccination status is up to date. That data wasn't accessible because it's largely fragmented. It sits with poor governance about who owns and who has access to it. Much of it is unstructured. So we have good methods to deal with structured data, like a lab test. We don't have good methods right now to deal with unstructured data, like a physician's note or a nursing triage note. And we don't have good ways to integrate across all of these repositories. So where is the opportunity with AI? Increasingly, you're seeing AI's ability, especially with the large language models, their ability to integrate multimodal data, which includes structured data, unstructured data, things like waveforms, and to put that all into usable information. And what we saw with the BlueDot innovation early in the pandemic was the ability to handle text reports very, very efficiently in real time to notify of risk. Imagine the capacity if we could extend that out to all of this clinical data, and that's the promise. Now, where could that take us? So if you use an example of where Canada was in the pandemic with respect to therapeutics, if you were admitted at a Canadian hospital, you were roughly 5 to 10 times less likely to be enrolled in a life-saving clinical trial of a cutting-edge therapeutic than you would be if you were in the United Kingdom. And part of the reason why is their ability to harness those repositories faster to connect a patient to a therapeutic trial. If you were in Canada, you were much less likely to get access in the first waves of vaccine rollout compared to, for example, someone in Israel. Part of the reason was the ability to harness their data repositories to match and then study what was happening as these vaccines were being developed. So we lost on a lot of the benefits that could be accrued. I would say Canada, if you speak to these manufacturers, to the trialists, to the therapeutics manufacturers and the vaccine manufacturers, we'd be one of the most desirable populations in the world to do this kind of work. We are the most multi-racial, multi-ethnic, high-income society on Earth. We're one of the most traveled high-income societies on Earth. So in a future crisis, many of these companies would want to work in Canada if we had the capacity to be a receptor for their innovation.
I know when I was covering genomic surveillance of the pandemic and of the virus, one thing that kept coming up in my reporting was all of the barriers to information, barriers that in some cases have been put in place for good reasons, but that were now thwarting a fast response. So, when you're talking about kind of mismatched data sets or the complications in kind of communicating quickly and at scale, what are some of the barriers that we need to consider so that AI could realize its potential?
Yeah, I think we spend a lot of time talking about the barriers. We talk about privacy concerns. We talk about vulnerable populations. Consistently in surveys of these populations, in fact, they want greater access and integration, but we often in the ivory tower or in policy circles talk about the barriers, not about the missed opportunities, which is what a lot of these populations care about. 5 years ago, when the pandemic set, I think a lot of these conversations were theoretical. But 5 years later, many jurisdictions have moved. I'll give you an example. So the United Kingdom is 60 million people, not much larger than Canada. We're now 40 million. They have an established mechanism for private sector therapeutics partners. In this case, it's a screening tool for early cancer mutations to work with the National Health Service to get access to data, find patients who may be eligible for a trial, who would benefit from early screening, contact them, enroll them in a trial. And in 9 months, they've already recruited 140,000 people in the United Kingdom using this method into a trial. These companies will never work in Canada unless we're able to get past, I think, our, to be frank, precocious sense of what is protection and what is opportunity here in Canada relative to other jurisdictions. And, I think in many ways we have to treat this as a race that we are losing at this point in a world that's changed a lot in the last 5 years.
Okay, lots there to pursue. Let me now turn to the audience. I encouraged you to have some questions ready. How about a show of hands? Are there questions here? Someone would like to, I see someone reaching for a microphone in the back. And we've got a couple questions here.
Hi.
So let's go to that one there. And then we've got a question right here in the middle. For next. Please go ahead.
My name is Brian Gregory. I have a question for the panel. Granted that the support of the public for public health measures is essential for the effective management of a public health emergency, I wonder if BlueDot or generally open source data has been used as a surveillance tool to gauge the public support, not globally for how well public health is doing, but for different public health measures.
I'm not sure if I totally heard the question. I'm sorry, I was having.
Could you just repeat that last bit? But you're wondering if BlueDot or others have looked at some of that.
Academics have used sentiment analysis to try to gauge public support for different public health measures during the pandemic. One stunning result showed that in Ontario, for example, the public supported local lockdowns, but not province-wide top-down lockdowns. I wonder if BlueDot in particular has thought about using open source data as a way of surveilling the public support for different public health measures.
Yeah, so thank you. Sorry, I couldn't quite hear it initially, but now so I understand the question. And one of the things that we can do with large language models is not just about counting how many cases there are or how many deaths there might be or that type of thing, but there's a lot of context that comes in some of the data that we're surveilling. So it could be public sentiment, it could be what medical countermeasures are there. There's a wide variety of contextual data that we're able to organize and structure. And so that's complementary. It helps put into context a particular event. And so that is something that we do on a regular basis. And it's part of the surveillance and intelligence gathering. So that helps the public health agency have a sense of like what's actually happening. Is there an intervention? Is there a response? Again, in some instances, there may be public sentiment. So there's a variety of other contextual factors that come into the surveillance that and intelligence gathering that we're doing on a regular basis. But maybe Fahad, you may have some.
Oh, sure. Yeah. I think it's a great question. And we certainly did do a lot of it during the pandemic. I mean, I think we used in a variety of ways. So we did more formal surveillance of people through surveys and focus groups, or kind of our traditional methods of understanding people's thoughts and behaviors. And I think the benefit of that still would have a place going forward in the future is it allows us to do segmentation of the population. Who is thinking what? I don't think we want to just know broadly, how many people are thinking of that. We want to know, what are young mothers thinking? What are older adults thinking? What are people in this part of the province thinking? So we need to have that segmentation. So you need to understand who is saying these things, and that there's still then that role for more traditional methods like that survey and focus group to get that information. But we also used it at that broader level. So we think about things like our travel pattern data that we were getting pretty regularly from Google and others to think about, where were people traveling? So depending on what the measures were in place, how much car traffic was still happening in the city? And was that people going from home to work? Was it going to different kinds of locations? So at that more macro level, we were using that information to understand, how well are people actually abiding to the requirements of the public health measures to say, is that actually working or not, or where do we still people traveling that seems to be out of character, and not so much at that individual level, but at that broad level, or where people are not complying, then how can we change that message? But what we lose in that is to know who's not complying with that message. So I think there's always still a role for that combination of both. I think things like the Google Travel Analytics will be only improved in the future as we have different kinds of data. I think we certainly have to be worried about the privacy impacts of that. Certainly Amazon knowing, that this person is going from this location to this location every day basically becomes identifiable data very, very quickly to know, who might be that person who's doing that. But I think it does give us that sense at a broader level, how well are some of these measures there. I think going back to that misinformation, that the challenge with scraping public sentiment is because there's so much echolocation of that if someone searches something, then they'll 20 more things will pop up. So does that actually represent people being that interested in this specific topic, or is that just the internet kind of doing its algorithm thing and seeming like an idea is more popular than it is? And I think we still have a long way to go to really disentangle that.
I think there's a question right here in the middle.
My name is Alexander, and I want to say thanks for the talk. I had a question. I like the analogy you used of finding a needle in a haystack, and I was wondering if you've run into any issues with the vast amount of misinformation and disinformation online, and as that grows over the years, how does BlueDot expect to adapt to this?
Yeah, it's a real challenge. I mean, I think this is a double-edged sword that we're talking about. On one hand, it actually can be very helpful for gathering and organizing and structuring information, but generative AI, we know, can amplify misinformation quite quickly. I mean, just think about the US election right now, and you can kind of see how very quickly a message can get a lot of traction that seems kind of like a ridiculous message. So it is a challenge, and I think the thing that we've done is we've got human subject matter experts in the loop. But that is also a challenge, scalability of how many people do you have as the volume of information becomes larger and larger. And in some cases, it's very challenging to determine, is that real or not? So we also have a whole network of collaborators across the globe, whether in the public sector, academics, et cetera. So in many instances, we're looking at some of these events and then trying to verify if the information is accurate or inaccurate. But it is a growing challenge. I wouldn't say I have, any of us have the answers just yet, but this, I think, will be a bigger problem as we go forward.
We have a question further afterwards. Then.
Hi, everyone. My name is Brian Schwartz. I want to focus on the title of this session, Readiness and Resilience. There's a body of research on resilience in particular, and a component of which is kind of the concept of facing down reality and getting rid of the magical thinking that we often saw during COVID. Each of you has addressed how to present that reality to various audiences. My question is, for anybody who wants to take it, or all of you, is what can be done now to build that infrastructure and systems that will contribute to the resilience from each of your perspectives for the next global epidemic?
Maybe we should have a science center that people could go to and learn about science.
Thanks, Brian. You didn't say that all three of us worked for you as well. So I'll start. I'll start with, I've kind of harped about the data environment for the country. I think getting information to people that is comprehensive, tailored to their local environment, and timely is really critical in this ongoing push back and forth between misinformation, uncertainty, the inertia of inaction, all of the factors that prevent people from doing something, responding in a certain way, taking protective strategies. I think information is critical to that, trusted, curated information that is timely. And by the nature of the way that our country has set up its data structures, the provincial, territorial, and federal boundaries that exist, the fact that hospitals are private entities that are not forced to share information, there's no mechanism that forces them. There's a lot of these barriers that we don't have to wait for a crisis to address. And, a lot of people have used an analogy about our data environment, comparing it to the speed limits that we set on roads. So there's been a public compromise around an expressway having a speed limit of 100 kilometers an hour. That is a limit that we accept that will have a certain amount of accidents inherent to it. Some will be serious, some will be fatal, but will allow also the population to get where it's going. And we can think about data in many ways as being similar. When you put on increasing restrictions, you slow the speed down. Yes, it's safer, but it could prevent you from getting where you need to go. And I worry that in Canada, the default always, because of often well-meaning intentions around privacy, governance, and other factors, have pushed us towards a zero speed limit in many ways. And we don't talk about the opportunity cost of not being able to get where we need to go, which is resilient, fast, responsive, comprehensive, and equitable structures for that next crisis.
Excellent. Let's have one more question right here in the front corner. Oh, sure. Absolutely.
Sorry. Thanks, Brian. When I think about resilience, I was actually just having a discussion with one of my boys about genetic diversity in crops yesterday, but it just got me thinking about this. To me, when I think about resilience, it's about having more diversity. And so when I think about diversity, this is not a problem government alone will solve. This is not a problem academia alone or civil society or the private sector alone will solve. So I think one of the ways that we've taken our approach is that ultimately, number one, is to be engaging a variety of different actors and thinking about ways that we can actually generate more, better readiness and awareness. And that actually happens through building relationships and building trust over time and really getting to know one another. It's hard work, but it takes time. And so for me, when I think about resilient societies, I think about this diversity of actors that need to be involved and building trust with these audiences. And this is something that, we've been doing at BlueDot for a long time, because I think as an academic, I tended to find that I was mostly engaging with public health. But now when I think about Amazon, I'm like, well, that's public health too. They got 1.7 million people. That's not a conventional path, but it is also a mechanism to build resilience.
Excellent. Thanks very much. So we did have one more question, and then we'll be wrapping up shortly.
Right. Thank you for your presentations. They're really informative. It seems to me one of the common themes of all three of you is the lack of information getting to the people that need it, like you, Dr. Razak, about like clinical information. So if you're saying that the hospitals are not providing all the information that they have, or that physicians are not providing the information in a timely way, and one of the big policy concerns, of course, is privacy. But it seems to me that there has to be some sort of some legislative changes that balance the two. And one of the ways I know people have talked about is scrubbing of personal information so that it is anonymized. And I'm just wondering if what sort of progress has been made, or do you think can be made, in order to anonymize the information and then legislatively compel the hospitals, compel the physicians to share this information in an anonymized fashion?
I think it's a great question, and I think it is that balance, and I think it is a challenging balance, as I was saying, around how do we leverage the information that we have while preserving that privacy. But I think where we are in the frontier of AI is that it's very unknown. And if there was a recent article from UBC in terms of Indigenous rights towards data and AI. And if you think about the things that are happening there around ownership and principles, you can ask AI, ChatGPT, to say, give me a picture in the style of Haida Gwaii, and it will. But is that really representative of Indigenous heritage and culture? No, I don't think so. And I don't think it'll be able to tell that same story. So I think we need to balance to say, who actually owns some of this data? If you scrub all that personal data, we lose the segmentation that we need. Being able to understand, was this person Indigenous? Was this person, from another country? What were those specific demographics? What is that specific socio-demographic data that we think is so important to understanding some of the differences in outcomes? If we scrub all that to make it so that we can share it, then we've lost the benefit. So there is a very delicate balance of saying, how do we need to know that socio-demographic data that's going to be really important to understand what challenges different outcomes, but being able to then leverage the power of aggregate data.
Yeah, I'll just add that we currently sit in a model where we're a data guardian, and we need to move towards a model where we're a data custodian. What is the difference? The custodian is responsible for not only holding the data securely, but for ensuring that it's appropriately used and the benefits are realized from that data, not just protection against the risk. I think Michelle and I both sit in sectors, in public health and in hospitals, where honestly, we could have done better about getting our data out. And I'll share the responsibility we had in data because we exist in a guardianship model and not in a custodian model. The legislation can be done. Again, we're not talking about something that hasn't been done in jurisdictions that we consider to be our peers. They are doing better in the United Kingdom. They're doing better in the United States. I spent 5 years in the United States. There's a lot to criticize, but for example, they know consistently now across their states and at a federal level, across race and ethnic groups, that certain groups did much, much worse during the pandemic. They can tell you that. We cannot give you that information in Canada because we don't measure.
I like to finish with a lightning round, and then we're going to quickly go to our wrap up today. Thanks very much for the questions you've asked. Here's the lightning round, and we'll go in reverse order. Just following up on Dr. Razak's comment, for example, about clinical trials. Imagine we're at a Prime Minister's round table. We're going around the table, 15 seconds. What would it take, or what tangible steps are needed for Canada? No, you first. For Canada or Ontario to be drivers of positive use of this technology rather than followers?
We have to hold our feet to the fire. You have to talk about the loss of opportunity, what you are losing as Canadians by not having this data accessible. Don't just talk about the risks.
Dr. Murti.
I would say the thing we need is better data in. I mean, garbage in is garbage out. And I think what we still fundamentally lack is, very basic public health and other clinical disease information systems to be able to fit in and provide that better data. So the key investment, if we're going to use AI, is better basic data.
Dr. Khan.
Time is the enemy. We lose focus very quickly. And as I showed early on, every 2 years, we're dealing with a global emergency. So we don't have time to waste.
Great thought to end on. So before we lose focus, please join me in a quick thank you for our speakers, our panelists. Talk about the rest of the series. Thanks.
Thanks so much to all of our panelists. Kamran for kicking off with a great keynote, Ivan for your excellent moderation skills, Michelle and Fahad, thank you so much for the time that you've taken to be here today. As has been up in the room and hopefully can be seen online, there is a QR code for continuing professional credits if you are looking for that link. And if you have not been able to use the link and would like to get it from us, feel free to email us after the session. We are looking forward to 2 more sessions in this series, one in October that will focus on using AI and crowdsourcing in resilient hospitals and enhanced patient care. That registration is now live for that session, so you can find it on EPIC's website, on IFP's website, on T-CAIREM. You can also, we'll email registration links out to everybody that registered for today's session. And then in November, we'll be having a discussion at our 3rd annual AMR symposium here in Toronto about accelerating discoveries in biology and medicine using AI. And that registration should be available soon. So thank you all for joining us today in person. Thanks again to our wonderful panel for all the discussions. I know there were lots more questions we didn't get to, but that's always the indication of a wonderful topic area and a lot of curiosity in the room and online. So thank you again very much today, guys. Thanks.